Hi, this is Brian Kim. I'm going to share with you this case of a patient with a traumatic cataract. It's not just a traumatic cataract, it's a cataract. And you'll see that there's also an iridodialysis. And once I start to take the cataract out, you're going to notice something unusual. You're going to see that there's a large posterior capsule defect and hole. And this case really illustrates why mechanical fracturing is a superior method to disassemble the lens, because you're able to disassemble the lens safely in the context of a posterior capsule rupture. So this is a case. You can see there's a large iridodialysis as well as a traumatic cataract. And in order to deal with this area of relative poor dilation on that side, and also to make sure there's no potential vitreous coming around that defect, you're going to see how I'm able to handle this. So after I make a corneal mark to help me to center incisor-rhexis, I'm going to place 2 iris hooks in those paracentesis spots. And so the reason why I love iris hooks in this situation, it's fully customizable and titratable. In other words, you can position the iris hooks exactly where you need it. As you can see here, I'm placing the iris hook, pulling the stopper back and then rotating it down and hooking the iris right over the area of iridodialysis. And doing it this way, I'm able to retract the pupil only in the area that I need it to. And this also helps keep that iridodialysis closed, and it helps reduce the risk for vitreous prolapse through the defect. So again, you just place it, twirl the stopper, and then you're able to hook the peripheral iris. This is intracameral epinephrine, and then some intracameral air, and then some trypan blue. I like to paint the anterior capsule surface. I don't want to push too much trypan blue and make it go into the vitreous space, which doesn't really make sense to me. And then dispersive viscoelastic to push the air bubble out, as well as the trypan blue. You can see there's beautiful dilation now because of the iris hooks. Again, fully customizable and titratable pupil dilation. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. And these are the sharp tip Haldey-Perkar forceps. I turn the teeth sideways, go in, puncture the center. And with these cases, you always have to be mindful of zonulopathy. You can see there's a little bit of looseness to the lens, but I'm able to puncture, pull the tear down towards me, grabbing the right side of the tear to create a flap, and then I'm going around circumferentially. I'm trying to make the size of the rhexis well centered and positioned to match the corneal mark that I made. You can see I have great control and minimal OVD egress. Burp some viscoelastic out, and this is the capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge, contra-incisionally, point the tip down very carefully, get a nice fluid wave, turn the tip sideways, come out, sweeping underneath the rhexis edge on the left side and pushing BSS as I do this. Do the same thing on the right side, and the lens begins to spin. Irrigating the surface of the eye, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, and then I'm going to go bevel up. And this is going to be the terminal chop technique. With these dense lenses, especially since I'm not sure about the zonules with this defect, I'm going to go ahead and sculpt, but I'm very careful to make sure I'm pushing as I go, but very gingerly. And this is in the dense cataract setting, using purely longitudinal to make sure I increase the efficiency of the cutting. and just very ginger. I don't want to push too much when I make the groove, being as zonular friendly as possible in the setting of a traumatic cataract with suspect zonules. So very carefully, I'm just pushing but cutting as I go. Don't want to push too hard as I go down. And again, you don't have to go too deep. I'm going to go bevel down now, and this is the terminal chop. I'm placing the chopper under the rhexis edge contra-incisionally, fracturing the lens through and through from the terminal side. And because it's from the terminal side, that fracture point is going to propagate all the way through and through from that one end of the pole of the lens to the other. So there's complete fracturing, as you see there. Placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phagotip. The phagotip is positioned deep, and I'm able to fracture the lens completely in half, cutting and pushing the chopper against the phagotip. And the phagotip is acting like a chopping block. Placing the chopper around that first quadrant, hooking the peripheral lens, pulling it centrally toward the phagotip, and crushing the lens against the phagotip in the same manner. Again, another cross-chop maneuver. So did you see that? I didn't notice it at the time, I don't think, but there is clearly a zonular defect right there. So I stop and I notice it right there. Oh, goodness. So I'm able to just continue here, and I'm going to hook the peripheral lens right here, pulling it centrally toward the phagotip, fracturing. So you can see very obviously now that there is a posterior capsule defect right there. But I'm going to go ahead and continue to break up the lens. So I place the chopper around the second quadrant, hooking the peripheral lens, pulling it centrally toward the phagotip, fracturing the lens completely in half against the phagotip. And very carefully and gingerly, I'm just trying to disassemble that second quadrant, breaking it up into smaller and smaller pieces, utilizing and leveraging mechanical fracturing forces, breaking it up into smaller and smaller pieces, and then emulsifying the lens pieces. I'm trying to stay away from that defect that is contra-incisional to me. And I'm able to leverage, again, mechanical fracturing forces and hooking the peripheral lens with the chopper to bring it up towards me. That's very important. At this point, I go ahead and stop, and I'm pushing some dispersive viscoelastic to tamponade the hole and any potential vitreous. So again, I push some dispersive viscoelastic over that defect, and I'm able to get better compartmentalization. So I'm able to emulsify the rest of that second quadrant, again, crushing the pieces into smaller and smaller pieces, and then emulsifying the lens pieces. So again, because I don't push the lens, I'm not trying to lollipop the lens, I'm not pushing down on the lens, I'm using the chopper to hook the lens up towards me away from the defect. And that's why it's such a powerful technique. And you can see now I turn that second heminucleus in front of me, and I'm able to place that chopper around the lens, hooking it peripherally, and then pulling it centrally toward the phagotip, fracturing the lens completely in half. And that is, again, another cross-chop maneuver. I'm doing the same maneuver with the third quadrant, hooking the peripheral lens, crushing it against the phagotip. I'm having opposing forces to crush the lens. I'm not pushing down on the posterior capsule. I'm not pushing against the zonules. This is a very friendly, zonular-friendly, posterior capsule-friendly technique. Again, none of those forces are pushing against the bag at all. And as a result, there shouldn't be any propagation of the posterior capsule defect. And as a result as well, because I'm not utilizing high vacuum into trying to grab the pieces, I'm not getting OVD removal, because if I have a lot of OVD removal, what's behind the OVD? It's vitreous. And so cases where you're having tough lenses and you're trying to lollipop them, remember these dense pieces are very jagged. And so in order to get purchasing power to hold it, you have to bury it into the piece, which means you have to utilize ultrasonic energy, you have to use high vacuum. And in doing so, it causes more and more OVD loss. And when you have more OVD loss, what happens? Then your posterior capsule is exposed. You have a higher risk for grabbing the posterior capsule post-occlusion surge, especially with these dense lenses. And then finally, it can cause vitreous to come forward. Because of this technique, I don't have to use vacuum. I don't have to use ultrasonic energy to disassemble the lens. I'm able to position the instruments around the lens pieces, crushing it into smaller and smaller pieces, and then using sparing amounts of and pulses of ultrasonic energy and vacuum, I'm able to remove the lens pieces. So again, this is the last piece. This is just the epinucleus. Now you can see very careful and methodical lens removal with this case. Again, no evidence for vitreous prolapse, no evidence for propagation of the posterior capsule tear there. Again, in my mind, it's very clear as day, especially since I used to perform sculpting techniques and traditional chopping techniques. I used to have cases where you have a dense lens and then posterior capsule rupture. And again, it goes back to what I said. It's because you're more dependent upon ultrasonic energy and vacuum to disassemble the lens. In this case, you saw there's this tiny little defect and it did not propagate. Very carefully, I push BSS. I take the phaco tip out. Pushing BSS, I make sure the chamber is well formed. And then I'm pushing dispersive viscoelastic to fill the bag, again, to tamponade and plug up the hole as well. And then now I'm starting IA. I'm very careful. I go in with irrigation off, activate irrigation. And I'm very careful to start subincisionally. And I'm going around circumferentially, peeling off the cortical material from anterior to posterior. And I'm trying to stay away from the defect. So I'm peeling the cortical material, subincisional, and then on the left side first. And then I'm pushing some cohesive viscoelastic to fill the bag before I come out with the INA. So I'm using the multimin, I'm retracting the iris to make sure that the defect did not propagate on either side. And it has not propagated. As a result, I'm placing a single piece acrylic lens into the bag. But then I'm very carefully, as the lens is opening up and the haptics are opening up, I'm using the viscoelastic cannula to dial and rotate the haptics in such a way that they are perpendicular to that tear. So again, very carefully, and you can use any instrument, but since I have the viscoelastic cannula in my hand, I use that cannula to rotate the lens in such a way that the haptics are oriented away from the tear. And then again, I'm using the multimin to just do a final check, retracting the iris on both sides, making sure that the defect does not intersect with the positioning of the haptics. So I go in with irrigation off, activate irrigation. I'm removing all the viscoelastic from the anterior chamber, and I notice something. I see some fluttering of the lens material right there, and that lens material is actually incarcerated with vitreous, and it is in the anterior chamber. You can see right there, it's fluttering around. And of course, though, thankfully, it's only localized over the defect. So again, it's a testament to my technique, the mechanical fracturing, cross-chop, mechanical fracturing techniques to disassemble the lens without using ultrasonic energy and vacuum. You can see and you can witness it very clearly that that defect did not propagate and the vitreous did not prolapse further into the anterior chamber. And so I go ahead and switch out and push BSS to keep the chamber formed. And then now this is a 20 gauge AC cannula as well as a vitrector. This is bimanual anterior vitrectomy from a limbal approach. And I'm okay with the limbal approach because the vitreous is localized right over that defect and we know where it's coming from. It's right from that defect. And of course, the iris retraction is also helping me see the vitreous. I have exquisite control. I'm not accidentally eating the iris. I'm not accidentally eating the capsule. Another reason why the customized iris retraction with iris hooks is so advantageous. You see here excellent control, and I'm able to perform a thorough anterior vitrectomy, again, through a limbal approach. Once I'm done, I'm pushing BSS in as I take the AC cannula out, and then I quickly start to hydrate the wounds. And now it's time to remove the iris hooks. You want to grab the hook proximally, pull the stopper back, twirl the stopper so the hook is rotated now more parallel, and then you're able to rotate it 90 degrees and pull the hook. Grabbing proximal, pull the stopper back, push it in so that the hook is disengaged from the pupil, rotating it 90 degrees, and now it's able to pop out quite nicely. So I'll go ahead and hydrate the incisions. You want to make sure you hydrate all of the incisions, and as I do this, you can see that the iris is rounding out. Again, the iris was puckered up like that because of the iris hook itself, not because there is vitreous over the incisions. You can see nice loosening of the iris contra-incisionally from me. You can see it's actually come down quite nicely. There is no evidence for vitreous in the anterior chamber. And so going back to this case, why is mechanical fracturing so powerful? Again, you saw terminal chop getting full thickness fracturing, able to avoid the posterior plate phenomenon, very efficient and very controlled fracturing of the lens. I made sure I didn't push down on the lens too much. You want to make sure you're gentle on the zonules in these post-traumatic cataract cases. You then saw multiple cross-chop maneuvers. Again, cross-chop allows me to hook the peripheral lens from the other side. By not pushing down on the lens, I'm not pushing against the posterior capsule defect. I'm able to hook the lens up and support it from the other side, and then fracturing it using the chopper to pull towards the phaco tip. Since the phaco tip is positioned in front of the lens, as I pull the chopper towards the phaco tip, it fractures the lens against the phaco tip like a chopping block. And doing this over and over again allows me exquisite control. I'm able to fracture the lens with opposing forces, again, pulling the lens away from the danger zone, away from the posterior capsule defect, and then crushing the lens into smaller and smaller pieces, emulsifying the lens pieces, using less ultrasonic energy and vacuum. Because I'm not relying on high vacuum and ultrasonic energy, I am not removing as much OVD throughout the case, as I'm using sparing amounts of ultrasonic energy and vacuum. Since I'm not removing that much OVD, this enables a more effective plugging up of the posterior capsule defect. By having more effective plugging of the posterior capsule defect, there's less risk for lens loss, where their lens pieces will fall into the hole, and there's also less likely that there's going to be more vitreous prolapse and exacerbation of the vitreous prolapse. And this is a prime example as to why I believe mechanical fracturing techniques are far superior to the traditional cataract surgery techniques. Again, this patient had traumatic cataract iridodialysis, customized iris retraction with iris hooks, and then mechanical fracturing in the way I did was able to very carefully and systematically disassemble this lens without propagating the tear, without having more vitreous prolapse. And at the very end, I was able to remove any vitreous that's in the anterior chamber and then finish this case. This patient, again, had a terrible cataract, long-standing, and thankfully, after the surgery, he had a clear cornea post-op day one, and his vision improved already to 20/50 from hand motion. So I hope this was helpful to you, and I thank you for your attention.